Okay, all right. Well, it is 8 o'clock, and so I am going to begin. Hello, everyone. This is Dr. Mariah Morris, for those of you who don't know me, and I will be doing the week 10 synchronous session. So, without further ado, I'm going to share my screen and we'll start at the beginning. Okay, so this again is the NU 632 week 10 synchronous session. And so let's start by reviewing the week 9 discussion. As you recall, we had a 16-year-old female who came in with complaints of burning with urination for 3 days. She had increase in urgency and frequency. She also had some decreased urine output. Burning with urination, abdominal pain, rating 6 out of 10. She had associated chills, nausea, and 1 episode of emesis. She's allergic to penicillin, and she's also had previous history of UTI. Here is some more additional positive history that you should have noted. She did not receive the annual flu vaccine. There is also some positive family history. And then her diet is not the best, as she cooks a lot of frozen food or eats out. So those are also some things we were looking for in that discussion. Okay, so the pertinent objective data, right? She had on exam, she had a CVA and suprapubic tenderness. And so this here is just showing an example of how you would palpate that. Okay, so what else do you want to know? So important items, her bathroom habits, right? Is she wiping front to back? Hopefully she is at this age, but that's also something you want to ask. What type of underwear is she wearing? We know cotton underwear is the best. Any douching or scented baths, bath bombs. And you might want to talk to the patient alone. She is of the age where she might be sexually active. And of course, if she's with another family member, she might deny that. But that is also sexual intercourse can also cause frequent UTIs. So you want to get that patient alone if possible and try to ask her that separately and privately. And then also ask about adequate hydration. We know teenagers are notorious for not having the best diet, not staying adequately hydrated. So that's also something you want to ask about. Okay, so here are some differential diagnoses. Again, this is not all of them, but these are some we were looking for. Of course, UTI, pyelonephritis, again, STD, as I mentioned. I know she said she was not sexually active, but she was also with a family member, so you want to ask her that alone again. And then cystitis. Okay, so what were planned? Well, obviously you want to obtain a urinalysis, right? That would be key diagnostics here, and that will help determine treatment. So if she does have UTI, you would want to choose an appropriate antibiotic. You could consider a KUB and possible ultrasound, only because she's had history. At this time, I probably wouldn't do that, but that's something to think of for future if she continues to have frequent UTIs, because there might be a structural abnormality. And so that's something to consider later on down the road. If it's a severe UTI with kidney involvement, of course, she would want to hospitalize that patient for IV antibiotics and treatment. Okay, so as nurse practitioners, what do? We educate, educate, educate. So education is key in this case. Of course, proper hygiene, cotton underwear, wiping front to back, avoiding scented baths and things of that nature. Adequate hydration, make sure she's drinking plenty of water. If you did prescribe antibiotics, which you should have, she needs to finish those, and she can take Tylenol as needed for pain. Okay, this here is a link. We've been talking all semester about clinical practice guidelines in pediatrics. And so when you see certain diagnoses, how do you treat that patient? What's the literature behind that? That's all part of the clinical practice guidelines that we want you to be researching and be familiar with. So here is an article. This link is active. You can copy and paste this. This will be posted. This recording will be posted, so you can copy and paste this link into your web browser and review the guidelines in more detail. Okay, so now moving on to week 10 content, we will be reviewing some musculoskeletal and neurologic disorders in children. Again, this is not an exhaustive list of pediatric diagnoses, but it's just some key items that we want to go over. Okay, so headaches. Headaches are something that you might see commonly in the pediatric population. And so headaches in children differ from adults, and so you want to know how to treat them. You want to know what the red flags are. You want to know the appropriate history questions to ask. So of course, with any type of chief complaint, you always use your old CARTS to acronym to develop your HPI. With headaches, we want to pay particular attention to the frequency. So that means how often they're occurring. Daily headaches are probably not migraine. So it's unusual to have a daily migraine. So if a child's coming in with headaches for the past month, usually that is stress related, anxiety, or could be allergies, right? If they have sinus headache, allergies, season, so that's something to think about. But if you're hearing daily headache, you can probably suspect it's not migraine. Obviously, worst case scenario, brain tumor. So, you want to be able to take a great history to differentiate those. Of course, severity and location, right? So we know occipital headaches can cause problems with vision, and frontal headaches, could be sinus related. So it makes sense. You want to ask a headache that is bilateral versus unilateral. Something that's unilateral is more concerning versus a headache that is bilateral. So. And then you want to ask about photophobia and phonophobia, because those are two key items that do go along with migraine headaches, along with any aura or things like that. And then family history. We do know that sometimes headaches, especially migraines, can be hereditary. So you want to ask about family history of headaches. Okay, moving on to your exam. Of course, you want to take a blood pressure, right? Because we know elevated blood pressure can cause headaches. Obviously, take a set of vitals as well. Vision screening. So sometimes in children, they might be complaining of daily headaches and maybe they need glasses. So you always want to do a vision screen, especially if they're having trouble saying they can't see the board and things of that nature. Palpate sinuses, because we can get a lot of sinus headaches in children, right? Their sinus cavities are not as large as adults, and so they don't drain as easily. Check for nuchal rigidity, right? That means we're ruling out meningitis. And you also want to check cranial nerves. Okay, so here are some red flags. If when you're asking, and so these are items you want to ask about in the history if the parent or child has not mentioned anything. Does the headache occur when they are first waking up in the morning? That would be worrisome. Or if a headache is waking them up from sleep. Those are two main things that are worrisome. If the headaches are increasing in frequency and severity, meaning they're getting worse, happening more often. Unilateral, I had mentioned that earlier. If you see any papilledema when you're doing your eye exam, that's worrisome. Again, nuchal rigidity, we talked about that for possible meningitis. Any headache that's causing change in mental status, that's concerning also, for brain tumor. And anything causing gait abnormalities could also be considered, with cyst or tumor. Types of headaches. And let me just briefly say that headaches in children, most of the time, are not pathologic in nature. So most of the time, headaches are not severe, not tumors, not migraine. So most of the time, they are not pathologic. So just keep that in mind. I know that differs in the adult population. Okay, so here are some types of headaches. Sinus headache, which occurs behind the brow bone and the cheekbones. So you want to palpate sinuses to see if there's any sinus tenderness. Cluster headaches usually occur around one eye. Tension headaches feel like a squeezing band around the head, and they can also radiate down to the neck and feel very tense. Those are tension headaches. And those usually are the ones that occur daily, as I was mentioning before. And then migraine headache, which we know can have photophobia, phonophobia, nausea, emesis. So those are some types of headaches. Okay, and briefly going over the treatment, first line, which would be your abortive medication, are Tylenol, Motrin, NSAIDs, Zofran if there's nausea and vomiting associated with the headache. Again, we never use aspirin in pediatrics, so you would not recommend that. And then for secondary preventative medications, so if headaches are, migraine in nature, and you've ruled out pathologic causes, you can do daily preventative medications. And so some of those would be antidepressants or antihypertensive, depending on, what you think would be the trigger of these headaches. Propranolol is one, amitriptyline, those are two that are used frequently in the pediatric population as the first line preventative. And then of course, when they're having breakthrough headaches, you would do the Tylenol, the Motrin. So these preventative medications, it's similar to what you would consider with asthma. You have your daily inhalers, and then when you're having an asthma attack, you have your rescue med. Same scenario here. So these preventative medications are taken daily, regardless if the patient has headache. These are preventative measures. They will not stop a headache if the patient's having a breakthrough headache. If that happens, you would still need Tylenol, Motrin. Sometimes you can do Imitrex, things of that nature. And then if the antidepressants and antihypertensives are not working, usually you would refer out to neurology at this point. I did pediatric neurology for 7 years, and by the time they got to us, they had tried everything. We ruled out pathologic causes, and we would do anticonvulsant medications as a daily preventative. So that's usually either Topamax or Depakote. Okay, moving on to pediatric concussion. So this is a hot topic, and one that's near and dear to my heart as I did my DNP scholarly project on pediatric concussion. So it's gotten a lot of mainstream news, and recommendations are improving. Back when I did my DNP many years ago, there really were not any pediatric guidelines for concussion. So we have all these children and adolescents and pre-adolescents participating in contact sports, and they were coming in with concussion, and there was really no clear-cut guidelines on how to manage these patients and how to treat them. And so the guideline at the time was basically using adult guidelines and trying to tailor that to children. And we all know that doesn't go that as far as we would like it to. So research is there, it's getting there, it's improving. And so here are some things you want to remember about pediatric concussion. Obviously, concussion is a brain injury. And a child's brain is still developing, so it requires a unique approach to care. Like I said, it's very different than the adult brain. So pediatric concussion should be treated differently than adult concussion. And you can have a concussion without losing consciousness. So that's usually one of the first questions asked. Oh, did you lose consciousness? Oh, well, it couldn't be that bad. That's not necessarily true. And concussions are more than just physical symptoms, right? So you can have mental, emotional, and behavioral changes after concussion. And that is something that I focused on in my project, because a lot of the return to play guidelines were just focused on physical symptoms. They weren't taking into account that many of these, they were student athletes. And so they were in school and they were having a hard time focusing and displaying some ADHD type behavior following concussion. And so that's something that's unique to the pediatric population for those student athletes that we want to consider. Most concussions do resolve quickly. However, 30% of people have symptoms that last longer than 4 weeks. And the key takeaway here is that you need to give your body optimal time to rest and recover. Returning back to play too soon is a major detriment to the child. Okay, so I'm not sure if you guys are familiar, but there are certain testing, key testing that you can do for pediatric concussions. So the first one is called impact testing. It stands for immediate post-concussion assessment and cognitive testing. And this is ideally done at baseline, so before the child has even started to play sports. And then you would repeat this testing after the child's had concussion, and you can compare the two. So you can determine, okay, well, this child's not back to baseline yet. They really should not be returning to play their sport. And here's a link. This is another active link that you can click on, and it will tell you more about this impact testing. The same goes for this link here. You can copy and paste that into a browser. Another evaluation that we use is called neuropsychology evaluation. Now, this evaluation can be used for many different things. It can identify learning disorders, ADHD, and things like that. But we also use it for concussion, right? Because it helps look at if there's any inattention, any social problems. It reviews memory, executive functions, all of the social development, personality, all of these things that can be affected post-concussion. Okay, so I mentioned this earlier, the return to play protocol. Again, this is still kind of a work in progress, but the CDC has come out with a 6-step progression. Most providers are following this progression. Of course, you might see some more specific guidelines, but this is a really good one to go by in the primary care setting. So it's a stepwise approach. So after the concussion, these are steps, baby steps, I would say. You take one step at a time to see how the child can handle and tolerate these steps. So the first one is just, are they able to return back to school following concussion? That's the first thing. Can they return to school? And now before you can progress, you need to wait 24 hours between each step before you can progress. And you also have to be able to return back to school fully. So if the child goes back to school and they're having problems with memory or inattention and focusing, then they cannot move to light aerobic activity. They need to stay in that particular step until they are symptom free. So they can return to school. Then the next step would be light aerobic activity, followed by moderate activity, and then heavy non-contact activity like weightlifting. Then they can go back to practice and full contact. Then they can go to competition level. And again, we want to remember to wait 24 hours in between each step. And you would fall back to the previous step if symptoms develop. And of course, obviously, you would like to wait 7 days for the child to return to play regardless, or to start these steps if neuropsychology evaluation is not available. And that was the evaluation I was talking about on the previous slide. Okay, so some key takeaways for pediatric concussion. The pediatric approach differs from the adult approach. You never return to play the same day of injury. You want to take that stepwise approach, that return to play protocol from the CDC that we just discussed. Perform impact testing, again, baseline and after injury, and do a neuropsychological evaluation. This here is an article that talks about clinical practice guidelines. Again, that is an active link, so you can click on that and it will go over pediatric concussion in more detail. Okay, so moving on to some common orthopedic injuries in pediatrics. So these are not all of the injuries you might see, but in a primary care setting, these are probably the most common, with the most common, of course, being strained ankle sprain, twisted my ankle, hurt my knee, sprained my wrist. And treatment for that, rest, ice, compression, elevation, that's not much different than the adult population. But fractures are different. So most fractures occur in the elbow or femur because that is in along growth plates. And to treat fractures, you would do that by casting. Stress fracture, that's caused by repetitive force. There's higher risk of this in kids because they have weaker osteochondral junctions. So that's another difference in pediatrics. Lacerations, contusions, same thing. That's an abrasion, a cut, a laceration. Depending on how deep it is, it might require sutures. Can be by accidents, falls. That's pretty much across board for pediatrics and adults. Shin splints. So another word for that is medial tibial stress syndrome. Treatment for that is to rest and heal, because if not, and you continue to do activity and exercise, you can develop stress fracture. And then plantar fasciitis. So if that occurs, we would tell the patient no running, jumping, long periods of standing. And to treat that, we recommend that you roll a tennis ball in the arch of the foot. Same for adults. So here are some orthopedic injuries specific to children. Something called subluxation of the radial head. You might have heard that called nurse's made elbow. And that results by, if a child's sitting and you pull them up by their arm, you're pulling them up from a sitting position to a standing, you injure right here, this elbow, the ligament right here. So you'll see here the elbow's pulled and the radius is partially slipped and you tear that ligament. So that's called nurse's made elbow. It's very painful for kids. It's most common in children ages 6 months to 5 years old. And to treat that, you want to do a reduction attempt. You'll hear a click. You probably would not want to try this in the outpatient setting. If you're not comfortable with this, you can always refer to ER urgent care, but that is how you would treat that to get that back in place. Brachial plexus injury, you'll see this in newborns. In some practices do newborn rounds in the hospital, but you might also see this in some of your newborn visits. And what that is right here, the nerves between the neck and the shoulders, they're stretched and compressed or torn during birth. So this is an injury that happens during birth, and it results in a weakness or paralysis of the shoulder and upper arm. So what you'll see, and it's classified type 1 to 4, with 4 being the most severe, depending on how bad the injury is. I would see this in neuro as well, and some children you could tell because they wouldn't use that arm at all, and some just had minimal movement, so it all just depended. If the child is breech or very large for gestational age, that increases the risk for brachial plexus injury. Maternal age over 35, and then also maternal pelvic anatomy can increase the risk. And during labor, the child might have shoulder dystocia if the child's large and that shoulder gets stuck, or if there was a vacuum extraction needing to pull the baby out. Those are also causes and risk factors for brachial plexus injury. Treatment for this, you really need to refer to a team that specializes in this type of injury. They might require surgical intervention, so depending on how severe the injury is. But this is definitely something that you want to pick up right away and refer, because the sooner the baby's treated, the better the outcome. Scoliosis, some of you might have seen this already in your clinical rotation. Very common in adolescents, or I shouldn't say very common, but that's usually when you would see it in adolescents. It's just lateral curvature of the spine. Idiopathic is the most common, and then congenital and neuromuscular. So on exam, you would see an unequal shoulder height, or the scapular or rib height, and you can see here it's uneven. And chest asymmetry, you might see that on exam as well. So you would obtain AP and lateral x-rays. Anything greater than a 10-degree curve or variant is considered abnormal. And if you notice this, you would want to refer to orthopedic surgeon. And then we recommend to start screening for this around age 10, but unless there's family history or you have cause, you can always screen sooner. Okay, next slide, we're talking about toe walking. So you might have seen this in your clinicals too. A lot of times parents will come in and complain, oh, my child always walks on their toes. And so most of the time this is normal and not cause for concern, and this should resolve by 3 years of age. And you'll see here, it's idiopathic toe walking. It's been estimated to occur in 7 to 24% of children. Again, most of the time it's normal, but by 3 years of age, the child should start walking with a normal heel-toe pattern. But some children continue to walk on their toes intermittently up until about age 5, and that can be okay too. However, if there's persistent toe walking, it could be indicative of a more serious neurological problem, such as autism, cerebral palsy, or muscular dystrophy. Unilateral toe walking usually indicates a possible hip dislocation. So most of the time when you see toe walking, it's both feet. If it's unilateral, you want to do a further workup. And then, of course, you would consider referring this child to neurology or orthopedics if you suspect there's an underlying pathology here. Okay, leg pain. So another name is growing pains. You might have seen that. And it's common. It occurs in about 2 out of 3 children. Most of the time, pain is located in the shin, the calves, the thighs, or the popliteal fossa. And it's usually bilateral. So if the mom's coming in saying the child complains of both of his legs hurting at night, you would think normal leg growing pains. And this is normal. This is not pathologic. This is not anything to be concerned about. So you would just provide reassurance to the parent. Analgesics is necessary for pain, and encourage the child to rest because it's usually caused by overuse. It occurs late in the day, at nighttime, and sometimes it can wake the child up, which could be concerning. But again, if it's bilateral and it's in the locations mentioned above, it's reassuring. It can last minutes to hours, but by the morning, the pain is gone. So when to refer? If there's any associated with swelling of any of the muscles or limbs, if it occurs in only one region, if it starts increasing in severity, or if it's affecting the child's gait. So those are reasons when you would be concerned and you would refer out to orthopedics. Okay, any questions on what we covered in this presentation? I see we had one person that joined us. Did you have any questions for me? No? Okay, all right. Well, thank you so much. And this presentation is recorded, and Dr. Snipes will post this so that you can watch the beginning of the presentation. Thank you very much.